Thank you. First of all, I would like to thank the organizers for inviting me. It's always a great pleasure to come to Australia. My conflict of interest is declared here. Actually, our department has received some funds for performing these trials. Nobody in my staff or myself have received any personal benefits. So we're talking about the two trials which we published as one paper. Just before I go into the results, let me just make a quick vote. How many of you have read the paper so that I know how deep I should go into the results? A small minority. Okay. So this is a multicenter trial, or two multicenter trials, which we published as one paper. They were phase 3 multicenter trials. And a specific feature, perhaps, in comparison with many others was that it was not just a double-blind, but also a double-dummy design, which means that when the patients were randomized to receive one drug, everybody also received another drug or a placebo, which was the doses were always changed at the same time, and all the infusion tubings were black so that nobody saw the color of the drugs, and also all the connections of the tubings were done by the study personnel in order to retain the blind. We had, in one of the trials in the MIDEX, 44 centers, PRODEX, 33 centers. The patient population was patients who were prescribed to have light to moderate sedation. We used RUS to score them, and the patient had been receiving either midazolam or propofol to start with. Randomization was within 72 hours of admission to the ICU, and within 48 hours of starting any continuous sedation in the ICU. We included daily sedation stops and spontaneous breathing trials, and the sedation depth was monitored at 2 hours intervals. The study had, or the studies had also two co-primary endpoints. The first hypothesis was to assess whether dexmedetomidine provides as good sedation in this target range as the standard treatments. So it was a non-inferiority design. And the second hypothesis, if that were the case, what was the impact of dexmedetomidine on the length of mechanical ventilation? The drugs were infused at their, the midazolam and propofol at their full accepted dose range, and dexmedetomidine at a maximum of 1.4 micrograms per kilo per hour, which is twice the level accepted at the US at the time of the trials. And dexmedetomidine was given without a loading dose. I'll go quickly through these flow charts, or the main issues in them. First of all, we screened everybody in the ICU, so not just all those who were sedated. So we screened about 15 to 20,000 patients, 8,000 in the MIDEX trial, 11,000 in the PRODEX trial were actually mechanically ventilated. About 8,000 in the MIDEX were excluded. 11,000 in the PRODEX were excluded, and if you look at those who did not meet the inclusion criteria, we realize that there's a huge population of patients with acute severe neurological disorders, about 2,500 in each of the trials. The second thing was that if you look at those patients excluded because they were not prescribed light to moderate sedation with one of these agents, we had only a very small number of patients excluded for these reasons. So obviously the target of mild to moderate sedation was widely accepted in these participating units. Perhaps another thing here, you can see we randomized 500 patients in each trial, 501 in the MIDEX trial, 500 in the PRODEX trial, and the follow-up was up to 45 days. The patient characteristics, the main things are shown here. First of all, you can see that these were fairly well balanced in terms of the study groups, it means that we had about 20 to 23% of surgical patients in the MIDEX trial, 37 to 31% in the PRODEX trials were surgical patients, so substantially more surgical patients than in most of the trials. But clearly these are the majority are still medical patients. There were some differences which I want to point out. One is that in the MIDEX trial, the patients receiving dexmedetomidine had more often an infection present at the time of the ICU admission, significantly more as compared to the group receiving midazolam. The organ failures present defined as SOFA score of higher than 2. The most common were respiratory and cardiovascular failures, followed by renal, coagulation, and liver failures. We did not assess the SOFA scores for the central nervous system, obviously, because the patients were sedated. So these are SOFA scores without the GCS assessment. To go quickly in the main results. First of all, as I said, this was a non-inferiority design to start with, which means that we had defined the margin of non-inferiority at 85% of the ratio of time spent in target sedation, excluding periods of receiving rescue medications. And we also observed, first of all, that in both trials, dexmedetomidine was actually non-inferior, and in fact, in the MIDEX trial, as you can see here, we were close to superiority, which would have been if the lower level of a confidence interval would have been above 1. What we also found is that there was, despite all this perceived and statistical non-inferiority, there was more frequent, significantly more frequent discontinuation due to lack of efficacy in both trials in patients receiving dexmedetomidine. So we can estimate from these results that approximately 1 out of 10 patients was not adequately or sufficiently sedated with dexmedetomidine. The main second co-primary endpoint was the duration of mechanical ventilation, and you can see here, first of all, there are 2 important things to realize here. First of all, we have the maximum time of study drug duration is 336 hours. It means this is the period of time where dexmedetomidine was given. Thereafter, after this maximum, the patients were sedated as the clinicians considered adequate. The second thing is that if you look at the format of the curves, you can see these curves crossing here, which means that, in fact, the hazards in terms of proportionality of hazards of being mechanically ventilated were not distributed equally through the whole study period. Therefore, we used the Gehan-Wilcoxon test to test the differences between the 2 groups, and this was true in most of the analysis, that we see this lack of proportionality of the hazards, which is most likely explained by the length, the maximum length of study drug duration. This is for PRODEX in contrast to the MIDEX trial, where the length of mechanical ventilation was significantly shorter with dexmedetomidine. In the PRODEX trial, there was no significant difference between the 2 groups. Most of the published papers nowadays, they contain an e-supplement. And that's the part which people usually don't look into. I strongly recommend you to look into, because there is much more information in these e-supplements than in the main papers. That's also the case with our trials. If you look at the time to extubation, we define mechanical ventilation as time when the patient received any kind of mechanical ventilation, including non-invasive. And non-invasive mechanical ventilation was fairly common in both of the trials. If you look at the time to extubation as another way to look at the dependence on mechanical ventilation, you can see the similar result in this analysis in the MIDEX study as previously. And if you look at the PRODEX study, you see also here now the difference becomes significant, favoring dexmedetomidine, hastening the time to extubation. In terms of length of stay in the ICU or in the hospital, we saw no differences. No differences whatsoever. So, shorter time of mechanical ventilation or quicker extubation, but no effect on the length of ICU stay or hospital length of stay. Mortality was a secondary endpoint or a safety endpoint. What we can see here is something which I can tell you when we opened the code of these trials. We first opened the MIDEX trial code, and when I saw these differences in mortality, I became fairly nervous. Because even if you don't have a statistically significant difference between the groups in the MIDEX trial, we can see that there is still an absolute difference of about 6%. It's 0.12. The p-value. In the PRODEX trial, we see no difference, and once we combine both of the trials, looking at dexmedetomidine versus standard care, there was actually no difference. What was clear that there was a difference in mortalities between the two trials, and I'll come back to that a little bit later on. A secondary outcome variable was the patient's arousability and ability to communicate. We measured that using VAS scales. The nurses in each shift, they used the VAS scale where they evaluated the arousability, the ability to communicate pain, cooperation with the nursing staff, and then we calculated the total sum of VAS scores from these scores. And we could see that in each of the trials, all these scales favored dexmedetomidine. I'll come back to that in more detail in just a moment. Adverse events are, of course, relevant. We can expect from the pharmacological profile of dexmedetomidine some typical adverse events. And in fact, we saw that hypotension was more common with dexmedetomidine as with midazolam, whereas in the PRODEX trial, there was no difference between the treatments. So propofol and dexmedetomidine were equally commonly associated with hypotension. Bradycardia, not surprisingly more common with dexmedetomidine, and there were just isolated cases of atrioventricular conduction problems. We looked at the neurocognitive adverse events in a different way. The reason being that we are not convinced that the CAM-ICU or the other tools for this purpose are ideal for such a sedation trial. So we looked at the reported neurocognitive side effects reported by the investigators. We combined them and we also looked at them separately, and there were clearly more neurocognitive side effects such as agitation, anxiety, and delirium in patients receiving propofol as compared to dexmedetomidine. There was no difference in the MIDEX trial. Here are the more details. This is once again in the e-supplement of the paper, where you can see that the profile in the PRODEX trial clearly favors dexmedetomidine having less side effects in these categories as compared to the propofol group. Also, if you look at neurocognitive adverse events which required concomitant treatment, we can see that there was the same signal detectable in the PRODEX trial, so more neurocognitive adverse events requiring concomitant treatment in the propofol group. We did CAM-ICU once after the patients were off the drug, 48 hours after stopping the study drug. We figured out that those patients who were off sedation at that time at least had their sedative effects more or less cleared, and therefore we chose this 48 hours as a follow-up. We saw no differences there between any of the study groups. Now, I understood from my invitation that I was actually expected to give you some more details than just what's reported directly in the paper, because to get your stuff published, you usually try to be at least slightly positive or optimistic in declaring that, you know, this is a positive trial and not a negative trial. But anyway, I think every trial deserves a closer look. Now, first of all, and this was reported in the main paper as well, and this is something we've been criticized of as well, is that patients receiving dexmedetomidine in both trials, even if they were at the same RAS score at the baseline, and they had same targets for the sedation, they were actually less sedated. In fact, I think it's a positive finding. I like to be criticized for that because these were randomized trials. The patient had similar sedative target ranges, and if they actually ended up of being less sedated, it's good. But that's certainly something you need to take into consideration. If we would have been able to maintain the patients on that lighter sedation with midazolam or propofol, maybe that would have been possible to have a similar reduction of their length of stay or their length of mechanical ventilation. But obviously, when the drugs are given at the clinical environment, this is the result that you get. You can see the same trend here we have. This is also in the electronic supplement. If you look at the stratification of different RAS levels, you can see that in both trials, patients receiving dexmedetomidine had a clear shift to more lighter sedation levels. If you look at the sedation stops, their duration, first of all, we can see that in the midazolam study, the MIDEX study, both drugs had sedation stops which lasted around 2 to 4 hours. If you look at the PRODEX study, we can see that the duration of sedation stops was much shorter. Why is that? I think that the explanation here is that in the MIDEX trial, all the patients had already received midazolam infusion, and what we are seeing here are prolonged effects of midazolam infusion preceding the randomization to the study drug. I have additional data which speaks for this explanation as well. Let's have a look at the sedation stops. First of all, if we take those scheduled sedation stops where there was no clinical contraindication, we recorded those. We can see that the range of no contraindicated scheduled sedation stops was about 75 to 84%, which if we compare that with the ABC trial, which was a trial comparing spontaneous breathing trials with or without spontaneous awakening trials or sedation stops, we are about in the same ballpark, 82%. If you look at the amount of scheduled sedation stops which were actually performed when there was no contraindication, we can see that the range in our trials was from 89% to 93.3%, which is actually, if you look at the ABC trial, you can see that there they did 95% of the eligible spontaneous awakening trials. So we are in roughly the same ballpark. Patients who never underwent the scheduled sedation stops, the range was actually quite low, 2 to 7%. In contrast, in the ABC trial, 10% of the patients never passed the safety screen for a spontaneous awakening trial. Spontaneous breathing trials, obviously perceived very important for the length of mechanical ventilation. The numbers here appear at the first look quite low, 47 to 59%. But if you go back to the reasons for the missing spontaneous breathing trials, you can see that there were, in the majority, there were either gas exchange, agitation, airway problems, hemodynamic instability, and these reasons actually could explain something up to 60 to 80% of the non-performance of these spontaneous breathing trials. And if you go back to the ABC trial, which could be sort of considered as the reference for this kind of practice, you can see that in that trial, about 15% from the whole trial of patients never underwent the spontaneous breathing trial of patients due not passing the safety screen. But you have to read this paper quite carefully to get into the bottom of the data. Because if you look at the safety screens that were passed, there were only 66% of spontaneous breathing trials actually performed in the APC trial. So in that sense, our results compare also fairly well in this respect with the ABC trial. So let's say that at least the argument that we would not have done these sedation stops and spontaneous breathing trials appears mute in comparison with the published data. There was another important issue between the ABC trial and ours, was that in the ABC trial, the median time from ICU admission to study inclusion was 52 hours, whereas in our trials, time from ICU admission to study inclusion was around 27 to 28 hours in both trials. So patients were started fairly early with the study treatments. There are still a few important details, and this is the part of the e-supplement of the paper which I bet nobody reads through. But these are important informations. First of all, if end time of mechanical ventilation was missing, time for being medically fit for discharge from study hospital ICU was used. That's nothing special. If the patient died, we did not use ventilator-free days. We just look at the absolute number of ventilated days. But if the patient died or ventilated, we consider the patient being ventilated for the whole duration of follow-up, so 45 days, which means these patients were worst ranked. If the patient was discharged from the ICU while still mechanically ventilated or ventilated at 45 days, they were censored at discharge or respectively at 45 days. For the length of study ICU stay, the readmissions within 48 hours were considered as same admission. And if the time of being medically fit was missing, then we used actual ICU discharge time, which is also nothing special. But also here, if the patient died while in the ICU or was discharged for terminal care, then they were also worst ranked to 45 days. So clearly, if the mortality is high or the patients are discharged to die in the wards, this clearly worsens the results of our trial. It's a conservative estimate of such data. For the time to extubation, a comparable approach. So if the patient died while intubated or was extubated for terminal care, the duration of intubation is considered to be 45 days, worst ranked. And the same was then true for patients who discharged from the ICU while intubated or were intubated for 45 days, they were censored at this time point. And similarly for the length of study hospital day, it's the same principle that if the patient was still hospitalized at 45 days, they were censored at this point. So one has to ask, how robust are these results? We placed the same question and therefore did a number of sensitivity analyses using the observed data only, so skipping all the imputations, censoring the patients at time of death instead of worst ranking them, and also looking at survivors only. These are all data presented in the electronic supplement as well. What you can see here is the length of mechanical ventilation, including observed data only in the upper part of the slide. And you can see here that in both trials, dexmedetomidine appeared better in terms of length of mechanical ventilation. Time to extubation using observed data only, same results. Both trials, dexmedetomidine appeared to result in shorter time remaining intubated. Looking at length of mechanical ventilation, censoring patients who died at the time of death, here we saw the dexmedetomidine being better as midazolam, whereas the difference between dexmedetomidine and propofol was not significant. And for patients who were censored at time of death, while intubated, we can see here once again both trials seemed to indicate favorable results with dexmedetomidine. So finally, looking at the survivors only, we saw that here the duration of mechanical ventilation was shorter as, with dexmedetomidine as with midazolam, but not different using propofol. So clearly, all these sensitivity analyses more or less confirm the results from the primary analysis, and perhaps laying more weight to the assumption that also in comparison with the propofol there might be some signal, but it wasn't significant in the primary analysis. We finally looked at the different subgroups, and you can see here just the mechanical ventilation, time to extubation, length of ICU stay, shown in the x-axis as median and interquartile range in hours. In the uppermost panel, you can see the whole study groups, and then underneath are various subgroups. Below and above 65 years, below or above the baseline median total SOFA score, excluding the CNS score, stratified according to the presence of infection at ICU admission, and you can see that in all these subgroup analyses also the tendency goes to the same direction. One important issue is, of course, why was sedation restarted by patients where sedation was stopped? And you can see that, first of all, there was a difference in the events of agitation being the reason in the MIDEX trial, in the uppermost line here. So more patients receiving midazolam had their midazolam restarted because of agitation as compared to dexmedetomidine. In the MIDEX trial, the second tendency to discrepancy or difference was during sedation stops a cardiovascular instability, which is quite interesting because here we had more cardiovascular instability during sedation stops in patients receiving dexmedetomidine. So in contrast to the expectation that dexmedetomidine would create cardiovascular instability, stopping it caused cardiovascular instability more often than stopping midazolam. In the PRODEX trial, you could see that poor tolerance to ET tube was more common in patients, tended to be more common in patients receiving propofol. The overall tolerance to mechanical ventilation was the reason for restarting sedation more often in the propofol group. And also the problems in weaning in general were reported as the cause for restarting sedation more often in patients receiving propofol. To go to MIDEX and the mortality, as I said, we were very concerned. We opened the code before the propofol trial was completed, and we really went to all the death cases. We reviewed each one of them separately by the investigators, and we sit down for a day and reviewed those conclusions. And in fact, the more striking thing that we found there was that if you look at the differences in countries participating, we saw that there was a major difference in mortality between the groups in Belgium and a smaller amount in France. This randomized trial, that can of course happen, that you have in some areas, you have an imbalance in the case mix, even though you don't pick that up with your normal case mix indicators. And when we looked at the causes of deaths, you can see that in the crude numbers of causes of deaths, you can really see no clear trend. But when we go to the individual countries, you can see that in Belgium alone, out of the 15 extra cases died in the MIDEX trial, there was a 6 head count difference just in patients dying of septic shock or uncontrolled infection in Belgium, suggesting really that we had a case mix imbalance which we did not detect in the normal case mix indicators. So conclusions, are we satisfied? One can never be satisfied, I think. But I think that within this context, dexmedetomidine appears to be an effective alternative to standard sedation, standard care sedation using either propofol or midazolam in patients who require mild to moderate sedation. But the caveat is that not every patient can be sedated with dexmedetomidine at this dose range. You will certainly be confronted with that in the clinical practice. If you comply with the highest dose range, you will not get everybody sedated. However, you also saw that if we were to use the allowed maximum dose ranges of midazolam and propofol, also many of those patients would not be sedated adequately. So there might be a dose equivalence question here involved as well. In our view, and in my view, dexmedetomidine seems to offer some distinct advantages. And first of all, I think that perhaps the most important thing was the apparent resulting lighter sedation. The patients were maintainable at a lighter level of sedation. The communication was enhanced, and in comparison with midazolam, the duration of mechanical ventilation was reduced, and there were less neurocognitive adverse events. We need to consider that DEX has relevant cardiovascular effects, which especially in hemodynamically unstable patients should be considered. However, as you saw, we had a fair amount of patients in a cardiovascular failure treated with vasoactive drugs at the time of inclusion of the trial. So actually for me personally, it was a surprise how well it was tolerated hemodynamically, even in these unstable patients. But it should be considered in the normal use. Thank you very much.
So these are pretty pivotal trials, and we got an opportunity to ask some tough questions. Go, Ian.
I'm interested in the systematic difference in patient cohort and accountable blood mortality. I was wondering how many ICUs were in both studies, and if there was a different, some sort of systematic bias as to why these patients were in
We preferentially, we asked the centers which was their practice. And in Europe, there is a division. You have the centers which in long-term sedation, it's midazolam only. And you have the centers where it's propofol only. In fact, if you look at the trials, there were, of all these about more than, well, around 80 centers, there were 2 centers who participated in both trials, who both said, you know, we use both in parallel. They were 2 completely separate. They were run in parallel, and as I said, there were just 2 centers participating in both. If we exclude them, the result is the same. And in terms of the case mixes, it's clear that the PRODEX trial was predominantly a Nordic trial. Most of the centers were from the Scandinavian countries, and then from Switzerland. And it is clear that the ICUs in these countries are organized typically so that they have a mixed population of surgical medical patients. Whereas if you go into Central Europe, you have much more ICUs who have mostly medical patients and just a small fraction of surgical patients. So that's one issue in the case mix. The other important issue in the case mix, of course, is that if you look at the mortalities in the control groups, in the standard care groups, in the two trials, we can see that they are fairly constant. Although we know that there are certainly performance differences between the countries and between the units. So this is a combination of factors influencing the case mix, but I think in the end with this small glitch in Belgium and France, we did it pretty well.
Can I ask two questions? A simple one to start with. The approach to analgesia in the trial was fentanyl PRN in each arm?
It was fentanyl continuous infusion or boli in both arms.
So that leads to my next question, which is, given the recommendations we've heard this morning from SCCM about an analgesia first approach, and given that dexmedetomidine is thought to have some analgesic effects, whereas propofol and azamolisinic do not have any analgesic effects, do you think some of the differences you found, perhaps in the arousability, the interaction ability of the patients, was just because of the differential effects of the analgesic effect of dexmedetomidine?
Well, if you look at the fentanyl dosages in both trials, even if there were differences in the RAS level favoring dexmedetomidine, it is clear that fentanyl was used fairly abundantly in both trials. And we actually didn't find any difference between analgesic use in the dex arms versus the control arms.
Yes.
How do you define the hypotension and bradycardia in your study?
Well, hypotension was, there were absolute limits, and there were limits which the clinicians considered as relevant. So bradycardia was, if I don't recall it wrongly, was 55 beats per minute, less than 55 beats per minute, and hypotension was mean arterial pressures below 60 despite of use of vasoactive drugs. So if you had hypotension treated with vasoactive drugs and normalized, that was not reported as a side effect. So it was only catecholamine resistant hypotension or hypotension generically reported according to the WHO adverse events reporting system.
Can I get to ask a question? So here in your table 2, you're looking at the dose of the study drug in PRODEX and MIDEX. Mm-hmm. So both of the groups are randomized to dexmedetomidine. And in the MIDEX trial, the dose of the study drug is 0.5 on average. In the PRODEX trial, it's 0.92. So like people that are randomized to dexmedetomidine in these centers basically got twice as much dexmedetomidine. They were blinded.
Yeah.
They didn't know what they were giving. That's a big difference.
That's a very big difference.
Is it because it's cold in the country?
Could be, I don't know. Interestingly, we looked at the in a sub-study, we looked at the pharmacokinetics as well, and there was a slight difference in the concentrations, but it was really minor. So obviously, it must be a pharmacodynamic and pharmacokinetic effect that we see there, and who knows? I mean, there might be genetic differences in the metabolism. We got some metabolic samples still under analysis, so I can't give you a straight answer to that. But obviously the concentration differences that we see do not explain.
It's quite, and the rescue medication in MIDEX was 195 milligrams, and in PRODEX was 17, still in the DEX group.
Well, those are different drugs.
Sure.
Because it's midazolam versus propofol.
Okay.
So it's in the MIDEX study it was propofol for rescue. In the PRODEX study it was midazolam for rescue.
Okay, very good.
A few years ago there were warnings put out about the use of exaggerated? Are there any dangers?
I mean, the reported incidences in a systematic review, which was recently published, assumed it was about 1% severe side effects from propofol. In the context of this trial, we didn't get reported propofol infusion syndromes. I personally suspect that there are much milder variants of the same which we just don't diagnose. So I must say I'm fairly concerned on the use of high doses of propofol continuously, even if in the context of this trial we didn't see major side effects there, but in my unit we tend to limit high doses of propofol very early because of I mean, we believe we see it every now and then, the side effects from propofol. Yeah.
Yeah.
Well, if we go to the pharmacopoeia, I think we would be, in my unit, we would be considering, let me say, if we give 200 milligrams per hour continuously, that's a very high dose, yeah. But it's really depending on who's on call.
Yeah. Another question there?
Correct me if I'm wrong, but the slide that he showed, the incidence of delirium was more in the propofol versus different
It was a combination. It was the combined neurocognitive effects, or do you mean the one where we assist CAM ICU afterwards? Neurocognitive side effects. Yes, there propofol had more reported side effects of agitation, anxiety, and delirium compared to dexmedetomidine. That's correct.
between dexmedetomidine and midazolam?
There was no difference there, and I think if we would go back to the data on, I mean, there are two issues. One is the inefficacy, the lack of efficacy. And one is these increased side effects. I think what we see in the PRODEX trial is the transition from the propofol medication before randomization to dexmedetomidine. And if you look at the lack of efficacy, the majority of the lack of efficacy for dexmedetomidine in the PRODEX trial occurred within the first 24 hours, and even in the first 6 hours, which is they were being titrated without a bolus to achieve the level of sedation target with dexmedetomidine. So I think that slightly puts propofol in a more favorable position in this comparison, whereas in the MIDEX trial we didn't see this shift at all. So I think that's also, that is the time point where we saw an accumulation of these agitation side effects that were reported during dexmedetomidine. Whereas those with propofol, typically they occur later. So the reported side effects of propofol typically came after 48 to 72 hours of propofol infusion, which I think also suggests another mechanism.
Yeah.
How much was the time between intubation and randomization? So how long time they were on non-study sedatives?
The time from ICU admission to randomization is 27 hours median in each of the study arms, 26 to 28 hours. I had it in one of our slides. So that was the median, and the maximum was 48 hours. That was by the protocol.
Another question there?
I'd like to ask a different random question. My name's Jukka, I'm a teacher from New Zealand. I'd just like to ask, who are all these people living on sedation? Because apart from people with very bad traumatic brain injuries, we don't actually sedate them.
Well, well, if you looked at the numbers of screen patients, we screened 12,000 patients in the MIDEX trial to get the 500 patients to be randomized. And we screened 18,000 patients in the PRODEX study to get the 500 patients. So in that sense, I agree with you. I mean, not all the patients need to be sedated. And then there was, of course, if you looked at the exclusion criteria, and if you looked at the patients who were excluded because they needed deep sedation, also those numbers are very small. So I think at least it seems to be representative for the practice we have in the European countries.
Sorry, just another question there.
When PRODEX was introduced to Australia, it was licensed for 24 hours of use and at a dose up to 0.7 mics per hour. From your studies and interpretation, do you think there's any side effects to using it for a protracted period of time and in much higher doses like we often do off-label?
Well, I think we went to 1.4, so it's double the allowed rate, and we went to 14 days. And Dr. Riker's study went up to 30 days in their setup. And clearly, I mean, Richard, maybe you want to comment that. I mean, we didn't see any accumulation of side effects over time.
Yeah, and actually there's almost an inverse relationship there. If you look at the first 24 hours versus beyond that and the incidence of things like bradycardia, hypertension, whatever, it's actually, in the SEDCOM study, there was actually more bradycardia late in the midazolam group than there was in the DEX group, and a much lower incidence in the DEX group compared to the first 24 hours. Some of that may be the people that are going to get bradycardic on DEX do so early and you stop the drug and go to something else. But I think the take home for us was if you don't see those autonomic kinds of things, the hypotension, the bradycardia early with DEX within the first 24 hours, I won't say it never happens, but it's uncommon to see it after.
Can I push the point just a little bit further? A lot of us have used it up to 2 mics per kilo per hour. Do you think there's a dose limitation other than the obvious kind of cardiovascular side effects?
You're pushing. I'm a hard guy to be pushed in this sense because I've never used it at higher doses. I mean, we are just getting the drug licensed in Switzerland. So I've only used dexmedetomidine in the context of the trial, so I have no experience. I know that my crazy Finnish colleagues use up to 4, but I mean, but I would be, I mean, it's like with any drug, I mean, pushing above the documented safety limit, you are in risky business. So I would just be, we don't have to.
Okay, one last question, because, yeah, go for it.
This is just a philosophical question. Do you think the MIDEX and PRODEX has changed the practice in Europe?
Well, I'm pretty convinced that it changed practices in the participating centers because, first of all, seeing that lighter sedation strictly conducted within the clinical trial is possible. That's the first thing. And I think that although all the units were required to have implemented the sedation scorings and sedation stops before they came to the study, I think many of those units were still in the fairly early phase of the implementation. So I think that once you've gone through this, I mean, there is no coming back. I mean, I've seen it in my unit, although we had implemented already years ago, but I mean, now the discussions are already quite the opposite as they used to be. I mean, everybody's questioning, you know, why do we need to sedate this patient? And so I think it's having a fundamental impact.